Okay, so you've shared quite a bit of detailed material on the clinical management of burn patients.
Yes, quite comprehensive sources.
Our goal here really is to dive into that and pull out the key insights, especially around how burn care has evolved and what best practice looks like today.
Exactly. And the materials really do show significant progress. Our understanding of the body's response, both locally at the wound and, systemically with metabolic changes, has really come a long way.
And that understanding directly influences treatment, right?
Absolutely. It's led to better surgical techniques, think more effective debridement, advancements in skin grafting, skin substitutes, and also improved infection control. All of this contributes to, well, shorter hospital stays and, importantly, better long-term outcomes for patients.
Yeah, and it's really interesting how the focus has broadened. It used to be almost entirely about survival, but now
Now there's so much more emphasis on prevention, for one, and managing smaller burns really well to minimize disfigurement, plus a huge focus on psychological well-being.
that whole piece about reintegration, back to work, back to school, and managing pain, ongoing wound care, it's all part of the package now.
Definitely. And one of the biggest game changers, I think, has been the combination of early, thorough debridement with really high quality intensive care.
That synergistic approach.
Precisely. That collaboration has dramatically improved survival, not just for massive burns, but also for those really complex cases, patients with inhalation injuries, other health problems, substance use, or even other trauma alongside the burn.
When we look at what determines survival, the sources are pretty clear. Age, the percentage of total body surface area burned, the percent TBSA, and respiratory injury. Those are the big three.
That's right. And for how long someone stays in hospital, age and percent TBSA are, again, the strongest predictors. But other things matter too, like how much of the burn is full thickness, female sex seems to be a factor, inhalation injury, and needing surgery, including things like esterotomy.
That point about inhalation injury always being considered major, regardless of the burn size, really stands out.
It does. It highlights just how serious it is. And while kids often heal remarkably well,
Their regenerative capacity is amazing.
it is, but comorbidities, other health issues still negatively impact their prognosis, just like in adults.
Okay, let's shift a bit to the demographics. The UK figures mention around 14,000 hospital admissions a year for thermal injuries.
Yeah, but the sources rightly point out that's just the tip of the iceberg. Many smaller burns don't lead to admission but still cause significant problems, sometimes even death.
And the US numbers are much higher, around 1 million hospitalizations annually.
That's the scale we're talking about. And of those, a certain percentage need referral to specialized burn centers. And within those centers, anywhere from, say, 4 to 20% might need intensive care.
It's also quite striking that nearly half of burns in developed countries happen in children, mostly toddlers under 3.
A very vulnerable group. The sources also list common causes, though we won't detail them all now, but burn centers also manage other types of skin loss, cold injury, friction, burns, even severe reactions like toxic epidermal necrolysis or 10N.
And we have to mention non-accidental injury. It might be less common, but it's critical to identify, especially in kids or vulnerable adults. It can be a sign of abuse.
Absolutely. The complexity of burn care really demands a team approach. You need experts working together for wound care, breathing support, nutrition, psychological healing.
A multidisciplinary team, the MDT.
Exactly. And a good team needs strong, clear leadership, someone who values what each discipline brings. It can't be autocratic, but endless consensus seeking doesn't work either.
So how does decision-making work in that setting?
Well, typically everyone's input is heard during rounds or MDT meetings. Plans are made, revised, but if there's disagreement, the clinical lead, often the surgeon, makes the final call. Regular meetings and constant communication are key.
And the core team members usually include, let's see, surgeons, nurses, anesthesiologists, critical care docs.
Therapists, physical, occupational, respiratory, clinical, psychologists, dietitians, infection control specialists, social workers, or community liaisons. And increasingly, there's a push to include a burn survivor on the team.
Which makes a lot of sense.
It really does. And planning for rehab and discharge, that starts basically on day one, even for the sickest patients. But the team's role goes beyond just direct care.
Right, things like data collection, research, teaching.
All vital. Good data collection helps us understand injury causes for prevention, track patient factors, monitor safety, especially infections, and measure how well our care processes are working. It's all about improving safety and quality.
And we need to look beyond just whether someone survives.
Absolutely. Quality of life after discharge is crucial. How are the scars? How's their function? Can they go back to work or school? Are they dealing with long-term issues like chronic pain, itching? And how are they recovering from things like inhalation injury?
So the whole team needs to regularly look at this data for audit,
Mm.
essentially.
Exactly. Use it to audit processes and outcomes. Maybe run specific projects if the data flags a concern. Follow that audit cycle rigorously to show you're actually making improvements.
And good data helps maintain standards, supports research proposals.
And helps when talking about funding and resources. A well-designed database makes this much easier, but even basic data collection is feasible and valuable, even with limited resources.
Ideally, you'd have national or regional databases.
That's the goal. It helps inform national prevention strategies and lets centers compare their quality of care, which helps lift standards everywhere.
What about research specifically in burn care?
It's essential for progress. But because severe burns aren't as common as some other injuries, multi-center trials are often necessary to get meaningful results.
And designing controlled trials must be tough, given how different each patient is.
It is challenging. But having good routine care data really strengthens funding applications and can even point towards new research questions. The quality of burn research is improving, though, with more randomized controlled studies being done.
And for developing countries,
Collaborative research can be a real lifeline there.
education is another big piece.
Absolutely. Starting with students in all the relevant fields, it's sometimes hard for them to access curricula focused on burns, though.
So burn teams have responsibility there.
Definitely. We need to make sure burns are included in undergraduate and postgraduate teaching. They're great examples of broader principles, like metabolic response to trauma or infection control.
The sources also touch on team health, which seems really important.
Extremely. Burn care is emotionally demanding. Cases of non-accidental injury, especially, can hit team members hard.
So you need mechanisms to deal with that.
Yes. Acknowledging those reactions, dealing with them outside the immediate clinical setting, maybe with professional help if needed, it's vital for keeping the team functioning well.
And that extends to personal crises or health issues too, I imagine.
It does, especially when workload is high. Getting help early can prevent long-term harm to individuals and the team.
Okay, let's move on to classification and prognosis. Standard practice is classifying by depth and percent TBSA, right?
Yes, for clinical management. But classifying by cause and location is also vital for prevention efforts.
And prognosis depends mainly on that percent TBSA, the amount of full thickness burn, age, and inhalation injury.
Those are the main factors. Comorbidities and other injuries definitely play a role, likely a negative one, but it's harder to quantify their exact impact. People have tried for years to create mortality prediction models based on historical data.
There was that 2015 study mentioned.
Yes. Highlighting that even in top centers, adults over 40% TBSA and kids over 60% TBSA face high risks.
And age as a factor probably relates more to physiological reserve. The idea of a frailty score for older patients makes sense.
It does. Though interestingly, one center showed improved outcomes in the elderly over 30 years, attributing it to better overall care and rehab.
What about hypothermia during initial assessment or surgery?
That's linked to poor prognosis in massive burns. It might impair the metabolic response or make patients more vulnerable to sepsis. There's also a link to increased risk of acute lung injury after brain surgery if the patient gets cold.
But predicting outcome for one specific patient is still hard.
Very much so. The approach should always be to assume survivability initially. Evidence suggests an optimistic attitude actually improves care. Decisions about futility or end-of-life care need careful consideration over time, based on the individual, not just the burn size.
And self-inflicted burns.
Tragically, they have a much higher mortality. Suicide attempts carry roughly double the odds of death compared to accidents with similar burn sizes.
It's good news that death during resuscitation is rare now.
Yes, most deaths now are due to later complications like sepsis and respiratory injury. The biggest drop in mortality has been in younger patients with massive burns, thanks largely to aggressive early surgery debridement.
And after removing the burned tissue, you need to cover the area.
Right. With the patient's own skin if possible, or substitutes if donor sites are limited, which is common in large burns. So things like cadaver skin, artificial skin, maybe cell-based therapies come into play.
Respiratory injury remains a major challenge, though. Hard to quantify severity sometimes.
Yes, it's quite heterogeneous. But we know prognosis is worse when burns are complicated by inhalation injury. Isolated smoke inhalation isn't usually fatal, but add a significant skin burn and mortality climbs. Add pneumonia on top of that, and it basically doubles again.
And the cause of death is often multi-organ failure.
Often, yes, not always directly infection-related. These patients have a bigger total injury, a second potential infection source in the lungs, need more invasive treatments, more anesthesia. It all weakens their immunity, making hospital-acquired infections more likely.
And some critical care drugs can actually harm the burn wound.
Potentially, yes. Inotropes, used to support blood pressure, can constrict peripheral blood vessels, possibly worsening burn depth or hindering healing.
It seems we haven't made as much progress with smoke inhalation mortality as with skin burns.
That's fair to say. Early excision and temporary cover work well for skin. But for the lungs, temporary support like ECMO is usually a desperate measure, and there's no lung transplant option for this kind of injury.
Let's dig into the pathophysiology. It all starts with the inflammatory response, doesn't it?
It does. The bigger the injury, the bigger the response. Skin injuries, burns, cold, friction, tendon break down that protective barrier. Surgery itself adds to the inflammatory load.
And smoke inhalation damages the lung tissue directly.
Right, causing local inflammation that messes with gas exchange. And if infection sets in, either in the wound or lungs, it just makes everything worse and prolongs that inflammation.
So a burn itself is basically damaged, coagulated tissue.
Or sometimes liquefied, it destroys the tissue structure.
Yeah.
And this damaged tissue releases altered proteins and chemicals.
Which the body sees as foreign.
Essentially, yes, triggering that defensive inflammatory response. In small injuries, this helps clear debris and start repairs. But in huge burns, without intervention, that response can spiral out of control and become life-threatening. And even if the patient survives, healing by secondary intention leaves major scarring.
And this inflammatory response involves a whole cocktail of mediators.
A huge list. Complement, acute phase reactants, prostaglandins, PAF, histamine kinins, neuropeptides, thromboxans, leukotrienes, interleukins, nitric oxide, free radicals, plus the stress hormones, catecholamines, and cortisol.
How does it actually kick off locally?
It starts with cytokine release from the injured cells. These cytokines activate the endothelial cells lining the nearby blood vessels.
Making them sticky for white blood cells.
Basically, yes. They express adhesion molecules, selectins, which slow down passing leukocytes. These leukocytes then express their own adhesion receptors, integrins, and they stick firmly. That's margination.
And then the mediators cause vessel leakiness.
Right. Things like histamine make the vessels dilate and open gaps between endothelial cells. Protein-rich fluid leaks out. Neutrophils squeeze through into the tissue's extravasation. You also get local hypercoagulability, which can impair blood flow, and oxidative stress damaging the vessels further.
That classic flare and wheel response we see.
Exactly. It gets phagocytes and fluids to the site quickly to clean up and start repair. You get these zones around the burn, the central dead tissue coagulation, then a surrounding zone of stasis where blood flow is poor but potentially salvageable.
That's the critical zone.
It is. Its survival depends on blood flow from adjacent areas, so it's vulnerable. Good fluid resuscitation and the depth of the initial burn are key factors here. Outside that is the zone of hyperemia with increased blood flow.
What about the lungs with smoke inhalation? How does the inflammation work there?
Inhaled smoke deposits hot particles and chemicals deep in the airways. This damages the lining, kills the ciliated cells needed for clearance, and triggers intense inflammation.
Leading to narrowed airways.
Yes, partly from edema swelling, which can mimic bronchospasm. But you can also get true bronchospasm from mediators like thromboxane A2. Plus, fluid leaks into the lung tissue itself, hindering gas exchange. Oxygen-free radicals and nitrogen species play a big role, and the balance of clotting factors in the alveoli gets disrupted.
And this lung inflammation can happen even without direct inhalation.
It can. Systemic inflammation from a large skin burn can trigger ARDS, acute respiratory distress syndrome. The mediators circulating from the burn wound can damage the lungs indirectly.
So understanding this led to early intubation for smoke inhalation.
Exactly. The risk of upper airway swelling from heat damage is just too high. Ventilation supports the lungs while they recover. But ventilation needs sedation, which has its own downsides, suppressing immunity, messing with fluid balance.
Management is mostly supportive then.
Largely, yes. Protective ventilation strategies, sometimes high-frequency ventilation, regular bronchoscopy to clear airways, meticulous infection control. There's ongoing research into therapies targeting those toxic oxygen species or the coagulation issues, things like inhaled anticoagulants or antioxidants, though some caution against overly invasive treatments.
And the specific toxins in smoke. CO, CO2, cyanide.
Right. CO2 causes stupor quickly, likely why people can't escape fires. CO above 50% is usually lethal, but prompt high-flow oxygen can manage less severe poisoning effectively. Hyperbaric oxygen didn't show benefit in one large study.
Cyanide is a big concern, too.
A huge concern. Lethal quickly, causes problems even in traces if untreated. Treatment really needs to be immediate, ideally pre-hospital. Hydroxycobalamin is recommended and available roadside in some places like France.
And the lack of oxygen in smoke itself.
That causes hypoxic injury, potentially leading to brain or heart damage. Those studies suggest permanent neurological issues might be more from asphyxia overall, not just lack of oxygen. Normobaric oxygen helps manage the acute neurological effects, especially in kids.
Okay, so beyond the local injury, there's this massive systemic inflammatory response.
Yes. And while inflammation is needed for healing, those mediators circulating systemically can be toxic to other organs: heart, gut, nervous system, lungs. Controlling this is key to managing the burn wound, but the metabolic response involves more than just inflammation. This whole systemic hypermetabolic state might be behind most long-term problems.
That's cytokine storm idea.
Exactly. Coined years ago. Studies consistently show high levels of pro- and anti-inflammatory cytokines in the blood, and patients are at risk of multiple hits: the initial burn, inhalation injury, big surgeries, sepsis triggering repeated storms, and risking multi-organ failure.
Which cytokines are the main culprits?
TNF-alpha and IL-1 beta seem to be key players in driving organ dysfunction, setting off cascades of other mediators leading towards shock and SIRS systemic inflammatory response syndrome.
And telling SIRS from actual sepsis must be tricky in burn patients.
Very tricky. Many sepsis criteria, like fever, are often present just from the burn itself due to hypothalamic resetting. You can't just give antibiotics based on SIRS criteria alone, but you do need to act fast if invasive sepsis is suspected.
So what's the key to spotting infection?
Look for change. Change on top of the existing SIRS picture. Changes in gut function, breathing, temperature patterns like a new swinging fever, increased wound pain, changes in how the wound looks or smells. Any of those should trigger a full septic screen.
Let's talk fluid resuscitation. This is fundamental early care.
Absolutely. It's about preventing shock from the massive fluid shifts due to leaky capillaries. For smaller burns, say under 20% TBSA and uncomplicated, it's fairly predictable. Hourly urine output is a decent guide.
But bigger burns are different.
Much different. The systemic inflammation affects everything. Prompt, adequate resuscitation definitely improves outcomes. Too little, too late is bad news. You even have to worry about reperfusion injury when blood flow is restored. Animal studies show heart cell damage with delayed resuscitation.
What about giving fluids enterally through the gut?
That can be effective in low-resource settings or if hospital access is delayed. Research is ongoing into optimizing those fluids to protect the gut.
And the mechanism of edema. It's not just about osmotic pressure.
No, the physical forces are huge. Interstitial fluid literally pulls fluid out of the capillaries. Capillary integrity starts coming back around 24-36 hours. Most leakage happens early when capillaries leak almost everything, including albumin.
Which means giving albumin early is probably pointless.
Likely futile, yes. It just leaks out. And if given early, it might get trapped in the tissues later when the capillaries seal up, making edema worse. A lot of that early fluid just ends up in the tissues, not the bloodstream, increasing edema and the risk of compartment syndrome.
And the heart takes a hit directly from the inflammation, too.
It does. Cardiac output drops more than you'd expect just from fluid loss, and it doesn't always bounce back fully even with resuscitation. Studies show measurable impairment.
So, could targeting the inflammation help with shock and hypermetabolism?
That's the hope. High-dose vitamin C has been linked to lower fluid needs, though outcome data is mixed. There are some warnings about it potentially interfering with glucose monitoring, too. NSAIDs have been looked at, but not really in humans yet.
So, early fluids are critical, but we still need to figure out the best way.
Exactly. Optimize it with minimal harm. The whole colloid versus crystalloid debate got stirred up by that Cochrane review on albumin back in '98.
Even though it had limited burn data.
Right. It led many to move away from albumin, even though older formulas using plasma proteins worked well. Around the same time, people noticed fluid creep giving much larger volumes.
Leading to concerns about abdominal compartment syndrome.
Yes, and raised compartment pressures elsewhere. The prognosis for burn patients who develop abdominal compartment syndrome is pretty grim. There was a suggestion linking morphine use to fluid creep, but it's more likely just the sheer volume almost doubling in some reports that's the main cause.
What about goal-directed fluid therapy, GDFT? applying principles from general critical care.
Results in burns have been mixed. One study showed increased oxygen consumption, but another found it just meant more crystalloid without actually improving preload or gut blood flow. Other studies also failed to show consistent benefits in hitting cardiovascular targets.
But some found standard formulas worked okay.
A Swedish study using Parkland formula guidance showed satisfactory hemodynamics. There's definitely been a recent pushback against overly aggressive resuscitation, a move towards permissive hypovolemia.
Are there better ways to monitor fluid status?
Maybe. Things like transpulmonary thermodilution and lactate levels seem more sensitive to low volume than just urine output and blood pressure. They might allow us to aim for lower preload and avoid fluid overload. Muscle tissue oxygenation is another area being explored.
So GDFT might not be the answer, or at least not with current targets.
It's still debated in general critical care too, but maybe measuring tissue oxygenation directly could be the way forward. A sepsis study linked adequate tissue oxygenation strongly to survival. We don't have similar studies yet in major burns to really quantify optimal resuscitation.
What's the latest on albumin and other colloids?
Recent evidence suggests albumin is generally safe in critical care, though maybe not equally beneficial for everyone. Just treating a low albumin number doesn't help.
Do colloids mean less total fluid given?
Generally, yes, to reach the same endpoints like urine output. In uncomplicated burns, that might mean less edema in healthy tissues. But with significant systemic inflammation, that advantage probably disappears.
And synthetic colloids.
Still advocated by some, but there are risks. Like kidney failure, some evidence suggests using albumin later in resuscitation, maybe after the first 12 hours, could be fluid sparing without increasing mortality. But does the benefit justify the cost? It's unclear.
So summarizing colloids. Albumin seems safe later on, but no clear early benefit or outcome improvement, especially with lots of inflammation. Synthetic colloids don't improve outcomes long term. Too much fluid is bad, too little is bad.
That's pretty much it. Finding the just right amount is the challenge.
How do we monitor resuscitation effectively then? Urine output is still common.
Widely used, yes, but the kidneys are often the first organ to fail. Some research suggests measuring intrathoracic blood volume might better reflect the inflammatory balance. Microalbuminuria for capillary leak and lactate for overall response are other advocated measures.
But standard monitoring blood pressure, heart rate, are blunt tools.
They are. You can have persistent tissue acidosis even when those numbers look okay. And achieving standard GDFT circulatory goals is tough in burns because of the capillary leak. Maybe they aren't even the right goals.
What are the alternatives being looked at?
Things like sublingual capnometry, looking directly at microcirculation with video, near-infrared spectroscopy for tissue oxygenation, base deficit or lactate for global perfusion. These might give us better insights.
Because the excess fluid doesn't just go out the wound or in urine.
Some of it inevitably ends up as excess edema in vital organs, impairing diffusion, possibly worsening organ failure. Comes back to that idea. The proper dose is enough. Not too much, not too little.
And defining enough is still the hard part.
Extremely hard with current evidence and monitoring. Advanced endpoint measurement might help in the future.
Okay, let's talk about hypermetabolism. That massive, prolonged response after a major burn.
Yes, driven by those high levels of catecholamines, cortisol, inflammatory mediators, it can last up to 2 years. Characterized by whole body catabolism, sky-high resting energy expenditure, REE, and organ dysfunction.
Have treatments helped reduce this?
Yes, things like early surgery, keeping patients warm, early continuous feeding through the gut, and certain drugs have definitely reduced morbidity. But the long-term consequences can still be serious, even after the wounds heal.
Like long-term health impacts. Increased cancer risk.
There's emerging work suggesting links, even with smaller burns, under 20% TBSA. The exact mechanism is unknown, maybe changes in immune response. There's also an association with later cardiovascular problems. Does the burn response unmask aging diseases? It's an open question.
So the main features are high metabolic rate, muscle breakdown, organ issues, insulin resistance, infection risk, poor growth in kids.
Exactly. Cuthbertson described the ebb and flow phases years ago, that initial shock phase, then the massive flow phase of hypermetabolism. If uncontrolled, it leads to exhaustion and death. We've made progress in understanding and managing it, thankfully.
Those high catecholamine and cortisol levels persist for months.
Can do, up to 9 months potentially, driving up RDE, heart work, oxygen use, causing tachycardia, liver problems, fat breakdown, muscle wasting, insulin resistance. Meanwhile, cytokines and acute phase proteins stay high, while things like IGF-1, growth hormone, sex hormones are suppressed.
And REE stays high even during rehab.
Often, yes.
Huh.
That muscle wasting is a huge problem, makes rehab harder, weakens immunity, slows healing, contributes to growth failure in children.
And the glucose metabolism is completely haywire.
Pretty much. High stress hormones lead to high blood sugar. The body makes more insulin, but it doesn't work properly, insulin resistance, so you get high glucose and high insulin or glucose clearance. The wound itself uses glucose anaerobically, making lactate, which puts more strain on the liver, fat builds up in the liver, and sepsis just makes all of this worse.
But early surgery helps.
Significantly. Removing the burned tissue reduces that toxic load, lowers REE, reduces muscle breakdown. But you have to weigh the risks and benefits. Timing, extent of surgery, technique, surgeon's experience, all matter.
And keeping patients warm is crucial too.
Yes. Losing thermoregulation means high fluid loss, high body temperature, burning lots of ATP. Warming the room 28 to 33 Celsius can cut REE by about a third.
How else can we modulate this hypermetabolic response?
Well, beyond early surgery and warmth, aerobic exercise and rehab helps rebuild muscle. Pharmacologically, recombinant human growth hormone, RHGH, can help boost IGF, suppresses some inflammatory markers, improves immune profile, speeds donor site healing, shortens hospital stay.
What about oxandrolone?
That's a synthetic testosterone analog, minimal masculinizing effects. It increases lean body mass, bone density, muscle strength, helps growth.
And intensive insulin therapy.
Aiming for tight glucose control, 80 to 110 milli-GDL stimulates muscle protein synthesis, improves bone density, reduces length of stay, probably works by improving nutrient transport into cells, fighting that insulin resistance.
And blocking the effects of all those catecholamines. Beta blockers.
Right, like propranolol. Reducing heart rate by 15-20% lowers cardiac work, metabolic rate, heat production. It also inhibits fat breakdown, helps the liver clear fatty acids, reducing fatty liver risk in kids, and promotes anabolism.
Are other drugs being looked at?
Yes, things like ketoconazole, GLP-1 agonists, fenofibrate, IGF-1, showing promise, but benefits aren't fully confirmed yet.
Nutrition is obviously critical in this state.
Hugely important. Early, aggressive feeding via the gut improves outcomes, short and long term. It maintains gut function, reduces bacterial translocation, preserves liver first-pass nutrition, way better than parenteral nutrition with its risks.
But working out how much to feed is tricky. Old formulas weren't great.
Often overestimated needs weren't adjustable. Measuring RE directly is better, but you still have to be careful not to overfeed. Too much carbohydrate, for example, causes problems. High CO2 production makes ventilator weaning harder.
So regular monitoring is key.
Essential. Plasma proteins, electrolytes, liver function, clotting, protein loss in urine, need to track it all to optimize feeding.
What about the balance of nutrients?
Modern commercial feeds are generally well balanced. If you meet the calorie needs based on REE, you usually get the macronutrients right. The latest ESPN guidelines give detailed recommendations.
Are specific nutrient supplements beneficial? Like glutamine?
Yes, post-injury glutamine levels are often low. Supplementing glutamine, arginine, omega-3s, antioxidants, micronutrients seems to help immunity and healing. ESPN recommends adding glutamine, selenium, and antioxidants.
And trace elements. Zinc, copper.
Evidence suggests burn patients need more zinc, copper, selenium, and vitamins like B1, C, D, E. We know they lose a lot from the wounds. Replacing them seems to restore tissue levels and benefit healing, infection rates, and hospital stay. Doses might need adjusting for kidney dialysis, though.
What are the potential problems with feeding?
Malabsorption, especially if started late. Diarrhea, constipation, feed intolerance, which can be an early sepsis sign, rarely serious bowel problems, and of course, under or overfeeding. Sometimes parenteral nutrition is needed as a supplement if the gut isn't working well enough.
Okay, let's switch gears to pain and analgesia, a huge area in burns.
Absolutely. Lots of research, especially on procedural pain, using patient-controlled analgesia, PCA, non-drug methods.
And the understanding of burn pain has evolved. It's not just nerve damage.
Right. It's nerve-ending damage plus inflammation. Mediators, the prostaglandins and IL-6 are involved. That old idea of pain being solely related to depth is too simplistic.
And the inflammation causes increased sensitivity.
Yes, primary hyperalgesia. And prolonged wound pain can lead to secondary hyperalgesia, where normal touch becomes painful. Those same inflammatory mediators also cause the awful itching during recovery, transmitted by slow C fibers.
So how should day-to-day pain be managed?
Prophylactically, regular combinations are best. NSAIDs carefully in the elderly opioids, plus adjuncts like gabapentin, clonidine, maybe ketamine. Combination therapy usually means needing less opioids, so fewer side effects.
What about 5-V lidocaine?
Advocated by some, but not widely studied, partly due to overdose fears, you absolutely need extra medication for breakthrough pain. Under analgesia is a real concern, especially if relying just on opioids.
So regular pain assessment is crucial.
At least daily, ideally every 4 hours. Adjust regular doses to keep pain scores low while the patient is alert and comfortable. And good pain control isn't just about drugs. It's addressing anxiety, helping sleep, a biopsychosocial approach.
Post-op pain needs aggressive management too.
Definitely. It's common and really hits morale. The WHO analgesic ladder might be a useful framework, though it's not specifically published for burn surgery pain.
And dressing changes often need anesthesia support.
For major burns, yes. 4V's short-acting drugs, sedation, sometimes general or regional anesthesia. Interestingly, patient satisfaction with pain control doesn't always match the treatment goals.
And managing side effects like nausea is important.
Vary. Might mean lowering the opioid dose, finding a balance, and managing itch. That's incredibly difficult, but so important.
What are the long-term consequences if pain isn't managed well?
Significant. There was a landmark study showing in-hospital pain was a stronger predictor of later psychological adjustment than burn size or hospital stay, independent of prior mental health. It's a direct, enduring link.
That really underscores the importance.
It does. It's why MDTs for burn pain are being promoted using that biopsychosocial model. There's even a tool developed to assess the anxiety component of burn pain.
And chronic pain after burns is common.
Unfortunately, yes. Many patients report it long after discharge, even after wounds heal. It can increase suicide risk, is linked with depression and PTSD, and hampers functional recovery. Chronic pain syndromes are rare but disabling.
So wrapping this section up, burn injury sets off this incredibly complex systemic response.
Right. Inflammation is key, essential for healing initially, but becomes detrimental due to the sheer load, the pain, the stress, drives metabolic chaos, organ dysfunction. Understanding things like the small vessel changes has led to better therapies like fluid resuscitation, improving survival.
But there's still a lot we don't know.
Definitely. Much more to learn about the injury itself and how interventions can influence its lifelong impact.
Well, thank you for walking through those sources. I really hope this deep dive has given our listeners a valuable overview of just how complex burn care management is.
Yes, hopefully. We've covered the incredible progress in survival and outcomes, the absolutely critical role of the multidisciplinary team, the intricate details of inflammation and hypermetabolism.
And the ongoing challenges, areas like fluid resuscitation, pain management, where we're still refining things.
Exactly.
So maybe a final thought for our listeners to mull over. When you consider everything that influences burn recovery, from the initial injury right through to long-term rehab, what seems like the most promising area for future research and clinical focus, is it about fine-tuning those acute interventions even more, or perhaps shifting more attention to lessening those long-lasting systemic effects of the injury?
An interesting question. We'd certainly encourage everyone to keep exploring this field based on what we've discussed today.